This is a recording taped following the live presentation performed on May 4th, 2022. Surgical education update, current projects and initiatives to support your programs. Presentation given by James Watterson and Christine Seabrook to the Children's Hospital of Eastern Ontario Grand Rounds, May 4th, 2022. By the end of this session, participants will be able to apply improved processes for competence by design and competence committees, identify opportunities for collaboration with the Office of Education, and implement measures for greater accountability among teachers and learners. Today's agenda: review of the current structure of the Office of Education, provide an update for competence by design, workflows and processes and standards within the Office of Education, and finally a brief update on accreditation. The Office of Education consists of 7 program administrators, 1 clinical placement coordinator, 1 bookkeeper, 1 skills and simulation coordinator, 1 manager. The Office of Education supports the following areas within the university setting, as well as the respective teaching centers. The current organizational structure is as follows. The various program administrators, clinical placement coordinators, and undergraduate program coordinator all report directly to the education project and office director, who ultimately reports back to the Vice Chair of Education and the Postgraduate Surgical Education Committee. In 2015, the Office of Education underwent a strategic planning meeting to develop a mission, core values, and various strategies. The ultimate goal is to facilitate sharing and implementation of best educational practices amongst all departmental education programs. The benefits of the Office of Education are multiple. Enhancement of educational culture in the Department of Surgery, increased communication and collaboration between programs, improvement of educational standards in all programs, the establishment of best practices for support and advancement of all programs, including at-risk programs, development of economies of scale with respect to simulation, CBD, and accreditation, development of administrative educational expertise, establishment of educational corporate memory, educational leadership at the Ottawa Hospital and the Faculty of Medicine is also provided by members of the Office of Education. Provide a resource for residency advocacy, wellness support within the Department of Surgery, and finally to decrease the administrative burden to program directors. A short list of some of the educational successes that we have been able to effect over the following years. Successful accreditation in 2016 and 2019, and active preparation for the upcoming Royal College accreditation in 2024. Development and implementation of competency by design in all surgical programs. By July 2021, 9 programs had been onboarded to competence by design using a structured, standardized approach to implementation, competence committee administration, and innovation at the Faculty of Medicine. With the COVID-19 pandemic in 2020, the Office of Education provided the ability to pivot to provide a virtual academic curriculum, CARMs, and research days for all of the surgical programs. Lastly, providing scholarship under the umbrella of the Office of Education has included various workshops at the International Conference for Resident Education, both at the Simulation Summit and the ICRE meeting, providing PGME workshops in both CBD and wellness, being consultants for the CBD Royal College Board, invited lectureship to the American College of Surgery to present on CBD, and lastly, various publications, both in the Royal College Program Director Handbook, through the SEED program, and finally, support of the previous O-score assessment platform. So moving forward with respect to CBD, there is a journey that we are currently on, and we're going to review some of the past, present, and future directions of CBD within the Office of Education. The first education night to introduce Competency by Design to the Department of Surgery occurred in June 2018, followed by a presentation to the faculty at large at departmental grand rounds in October 2018. Timeline depicts the various onboarding of the various surgical programs over the following years. In order to develop the various structured approach to CBD implementation, it was important to reflect on the requirements for success in the world of CBD. The CBD resident is the focal point that requires support from the various tiers around them, requires a standardized approach and process of implementation at the Royal College, postgraduate level, and Office of Education. The multitude of resources need to be curated. Administrative support is an absolute necessity. Program collaboration and sharing of best practices is facilitated through the Office of Education. Program directors and CBD leads need to be engaged in this whole process. And the various evaluators and faculty members also need to be committed and engaged. There needs to be a functional e-portfolio with the ability to report on resident progress. A competency committee needs to be engaged and functioning. The resident themselves have to be fully engaged in this process of CBD. And there needs to be ongoing faculty development provided at the various levels. The Office of Education developed a strategy for CBD implementation for the various programs within the Department of Surgery, with the development of a CBD manual that outlined these standardized processes, the development of an Office of Education onboarding team that was able to provide the necessary support and direction for onboarding of the various programs, ongoing faculty development in the Department of Surgery through grand rounds and program rounds, PGY1 onboarding to introduce CBD is provided not only in the various individual programs, but at the Department of Surgery Office of Education onboarding for PGY1s during their first week of residency. Ongoing EPA awareness is required and has been provided by the Office of Education using various different educational resources, such as lanyards, iPad stickers, clinic posters. The Office of Education provides ongoing e-portfolio support, as well as continued advocacy and collaboration with the postgraduate medical education for ongoing dashboard enhancements. And lastly, continued work on standardizing competence committee workflows in order to ensure an efficient assessment of residents at the competency committees. The Office of Education has developed a Competency by Design manual that has been published to the Apple iBooks and is free for access. So a reflection on how we are doing. At the Royal College level, there are ongoing evaluations being performed, looking at how programs are adapting to CBD, including national studies on readiness to implement, fidelity of implementation, and lastly, outcomes. The Royal College findings are multiple, and that most programs generally feel that their leaders are receptive to change and believe that successful launch of CBD is a priority. 80% of pre-implementation tasks are completed by programs on average prior to CBD launch, and programs are most prepared for implementing competence committees and orienting residents. Some of the challenging tasks include engaging off-service disciplines, conducting faculty development, and enlisting adequate support staff. Some of the earlier outcomes and positive outcomes include that residents are receiving more actionable feedback, struggling residents are identified sooner, there is more engagement and ownership in resident learning with enhanced clarity of program requirements. Some of the unintended negative consequences include fatigue and burnout, impacts on resident wellness with unintentional loss of a more holistic view of residency training. The Royal College will continue to monitor the negative outcomes and implement changes where need to ensure CBD is achieving what was intended and is not having a detrimental effect. There was a program director pulse check that was performed looking at the cohorts between 2019 and 2021 with the various benefits and challenges as outlined here. The Royal College CBD Program Evaluation Committee looked at the overall level of satisfaction with CBD according to resident physicians, and it was noted that CBD is the most stressful element in their residency. The theoretical advantages of CBD are recognized, but the anticipated benefits are not being enjoyed by resident physicians. With additional workload for residents and faculty, little time and few resources dedicated to it, the addition of a multitude of paperwork, responsibility of EPA evaluations lying within the resident doctors, with feedback sometimes being inadequate or incomplete, leading to a high anxiety levels in resident physicians. A recent study presented at the CCME 2022 by the Resident Doctors of Canada demonstrated these concerns with challenges with the EPA portal, evaluation fatigue, EPAs being viewed as redundant, distracting from learning and time consuming, staff not being properly trained or knowledgeable in CBME, low quality feedback, and difficulty keeping track of EPAs. Some of the CBD challenges that I believe are facing us still include changing attitudes and existing cultures in the various programs, resulting in difficulties in change management, anxieties or feelings of helplessness, inertia, and lack of engagement are commonplace, continuing to work in silos between programs and the various universities, and lack of practical knowledge or standardization implementation strategies, both at the Royal College, postgrad, and CC composite committees. And finally, limited resources and support, both from a personnel as well as the electronic portfolio. Some of the common roadblocks to assessment, and the fact that assessments are not being done on the spot, resulting in lost evaluations or poor quality feedback. Residents find it challenging at times to request assessments and feedback due to time pressures, sense of feeling like bothering faculty, desire to avoid poor assessments, and lack of pre-existing culture. Finally, the staff are not initiating assessments and feedback on a regular ongoing basis, relying only on residents to request. It's important to stress that this is a shared responsibility. Going forward on a day-to-day basis, what to expect with CBD. The role of the resident is really to trigger assessments and arrive with a predetermined learning objective. The role of the staff is to create teachable moments and allow time to assess and provide feedback. The competency committee itself needs to ensure a comprehensive review of the resident and to recommend to the RPC the trajectory of each resident. Finally, the role of the RPC is to ratify the decisions made by the competency committee. Some practical tips for residents. Non-CBD residents are crucial to the overall success of CBD. They are evaluators for early stages of CBD and also helps to establish a culture of evaluation of junior residents by senior residents. Residents do need to have awareness of EPAs and to identify daily assessment opportunities. Residents do need to have a working knowledge of the electronic platform at the University of Ottawa as Elantra and will be drivers of their own EPA completion. And lastly, when it comes to EPA assessments, it's important that the assessors are engaged prior to the activity and it does provide an opportunity for self-assessment while completing an EPA. Some of the practical tips for completing EPA assessments, including engaging the assessor ideally before activity, self-assessment of the EPA by the resident provides an opportunity for self-reflection to capture teaching points and visualize surgical tips. Completion of the EPA by a faculty in person is recommended, and this is to ensure that we minimize lost evaluations. This provides a great opportunity to discuss teaching points and surgical tips with an easy completion of the EPA by signing off with the predetermined PIN number. Avoiding emailing EPA assessments, as these lead to a high rate of stale assessments. For faculty, some of the practical tips including it's necessary to be aware of the various EPAs, and for those of us working at the University of Ottawa using the Elantra portfolio, all that is required for general faculty is knowledge of your own PIN number. And it's imperative that there's a positive culture of assessment. So simple things, offering an EPA assessment, taking time for that assessment, and capturing the informal teaching points that happen anyway during the activity or surgical procedure. There are a variety of different resources at the Royal College on how to be a better CBD coach, and I would certainly encourage those to visit the various resources. So what happens when it comes time to evaluate a resident at the competency committee? Well, the competency committee workflow that was developed initially was really constructed prior to the Royal College CBD launch. And so there was no real practical or Royal College guidance or PGME guidance, just due to lack of experience. Additionally, there were deficiencies in the Elantra electronic platform, and this led to obviously multiple different competency committee workflows developed in the various different departments. In general, the competency committee workflow requires the following. Prior to the competency committee meeting, there needs to be work performed by the reviewers and the program administrators. The primary review then is required to be sent back to the CC chair in preparation for the CC meeting. At the CC meeting, the primary reviewer presents their summary of resident progress review and recommendations regarding signing off the various individual EPAs. The competency committee discusses resident progress with a review of sample of primary data. And finally, the CC chair will draft a report to bring to the RPC with the various recommendations regarding learner status and progress. At the RPC meeting, scheduled typically within a couple of weeks of the CC meeting, the CC chair presents the information and recommendations for discussion at the RPC and final ratification. Following the RPC, the residents need to be informed of the decision and of their progress with any pertinent feedback. So with that in mind, we set out to improve workflows within composite committees and really to update the standardization of the composite committee workflow, reduction of duplication of efforts, improve efficiencies for the primary reviewers, the program administrators, the actual composite committee process, and finally the development of RPC reports, looking to capitalize on improvements and enhancements in the Elantra visualization dashboards, with the ultimate goal of providing a more robust review of resident performance. These CBD enhancements have been facilitated through the following: development of a composite committee fillable form and various video walkthroughs to guide the primary reviewers through Elantra in order to effectively look at the data that is within Elantra. There have been various visualization dashboard improvements, both for resident, faculty, and program evaluation. We also feel that there is a need to provide guidance regarding EPA standards. These have been guided through some of the discussions that have taken place at the various composite committee chairs, updates, and webinars. Additionally, we feel that there's an importance to continue with an end of rotation ITAR with the development of a generic ITAR that is CanMEDS based in order to explicitly evaluate a resident's performance within the CanMEDS domains. Lastly, there has been introduction of a logbook in Elantra where residents can input their various data regarding their surgical experiences. This is just an initial snapshot of the Department of Surgery Composite Committee Resident Status Report. This is a fillable report that can be filled out by the primary reviewer. As stated, there have been multiple different enhancements of the various visualization dashboards, looking at EPAs throughout the various rotation schedules and acquisition metrics. There is access to normative data so that residents can be compared to their various peer groups within the various stages of CBD. There are now faculty evaluation and metrics that can be fed back to the individual faculty members, looking at their own EPA assessments and where they fit into the overall normative data regarding faculty evaluators. And finally, there is now data looking at program evaluation and improvements over the years. As stated, EPA standards have been discussed, and we feel that there's an importance to have a set minimum number of EPAs achieved per week by the residence period. 3 EPAs per week or 12 per rotation should in effect give adequate number of assessments for the primary reviewer and competency committees to effectively evaluate a resident's progress. We're hoping to implement this as a Department of Surgery standard to ensure engagement of the resident and program in CBD, and as stated, to facilitate overview of the resident progress at the CC. The generic ITAR has been redesigned and redeveloped for an end of rotation evaluation. This has been recommended by the PGME. This new form is CanMeds Explicit, and because it will be standardized for every end of rotation evaluation, an aggregate report can be easily compiled prior to a competency committee to facilitate review of multiple reports. As stated, there's also now a logbook feature in Elantra where residents can log their surgical activities. Lastly, touch upon accreditation update, review the process and CAN-AMS platform with both the Office of Education Responsibilities and Program Director Responsibilities, review some of the internal review deficiencies that have been identified, and lastly, review program surveys to identify any program deficiencies or concerns. The Office of Education has developed expertise with the CAN-ERA platform. This outlines the new 2020 standards and the documentation process that's required prior to any internal or external review. So finally, in conclusion, it's important to note that the Office of Education has been developed and has now become an integral part of the success of all of our surgical programs, and that we do provide a wealth of expertise and support to our programs, and that we're here to help.